Thank you so much. So welcome to everyone today. I'm Mo from the PBC Foundation, and today we've got Professor Neuberger with us. Thank you so much for joining us again. I feel like it's ages since I've seen you, so it's really lovely to see you again. And we've had some questions sent in this week, so we'll make a start on those. But please just remember, I just want to give you a little caveat about medical information. So please just remember that Facebook is a public forum. So you need to be mindful of that when you put any questions in. And just remember that these Q&As do not take the place of a consultation with your own clinician. In these sessions, we aim to provide general medical information and not medical advice. So we've had quite a few questions sent in this week, so I will make a start on the first one for us. So the first one is, I was recently diagnosed with osteoarthritis by a rheumatologist and blood's positive for scleroderma antibodies. I was told the results were due to PBC and not to worry about another autoimmune disease. Is it connected?
Can I say before we start, I think you said this is the 100th Q&A?
It will be, yeah. In fact, I think there have been more that have been live, especially when we started during COVID, but when we upload this one, it will be the 100th Q&A that we have live on our YouTube channel, yeah, which is quite amazing, isn't it?
I think it's an amazing achievement, but the other thing that struck me when you sent me the questions is, yes, there are some recurring themes, but there's also an awful lot of new questions, new aspects, new questions. And I was really quite surprised, not only the number of questions, but the variety and all the concerns that people have. And I think it's great that the foundation does provide a forum where people can get information. But as I was struck by the huge breadth of questions, and this is just one, and there'll be many more, I think, today. Mm-hmm. So I think it's great. And it does, I think, emphasize that the foundation is providing a service. It's a sad reflection, perhaps, that it's needed, but it's there. And it's great. And it's only because of people dialing in, ringing in, watching the videos. So I think it's a real achievement, which the foundation can be justly proud. That said, let's move on to the...
Let's get going with the questions.
Yeah. Osteoarthritis is basically wear and tear of the joints. And as people live longer, often get heavier, the joints often tend to wear. And osteoarthritis is more, people are now, I think, thinking of it more of an active condition rather than just wear and tear. It does come in phases. You get bad days, bad weeks, bad months, but also respite. And it's probably slightly more inflammatory than people thought than just mechanical, although that's a major thing. Now, anti-centromere antibodies are an antibody that is associated with a condition called scleroderma or sclerodactyly. And that is probably an autoimmune condition whereby in scleroderma, the skin can get affected, it gets thickened, and that is associated with the presence of anti-centromere antibodies. You do see these antibodies more in PBC, and there is an association with PBC, and there is an association of PBC with scleroderma. Most of the scleroderma that I've seen people with PBC, the huge majority of those with scleroderma have it just affecting their fingers. They become a bit like, a bit sausagey perhaps, a bit like Prince Charles, or King Charles, I should say now. And it doesn't usually cause problems. Scleroderma can be a much greater condition affecting not only the skin, but the gut as well. But on the whole, if you're well, asymptomatic, then the fact that you have these antibodies present, I wouldn't worry about. So yes, there is an association between scleroderma and these anti-centromere antibodies, if these are the ones you have. There is an association between sclerodactyly, which is the more localized form that we see. And so yes, it's all part of the autoimmune spectrum, if you like. But the important thing is you treat the person, you treat the condition, not the antibody. If you do get Raynaud's phenomenon, that's where the skin goes, or the fingers go white and painful in the cold. Again, there are sensible habits that you can follow, like avoiding the cold, keeping your hands dry, and so on. But on the whole, it's a minor issue, and it's just, if you like, part of the PBC approach. I don't know if that completely answers the question.
Yeah,
can I
I think
just?
so, yeah.
Yeah.
It's good to get an overview as well, just for any other patients that are listening as well. It's always quite good to get a general overview as well, so that's great. Our
Sorry, I
next
must start
question.
looking at the camera and not at my big screen, so I'm always looking slightly off kilter, so I apologise for that.
That's okay. So the next question is, are weight loss injections safe when on urso, and also if you have atrial fibrillation and on bisoprolol?
Weight loss injections, if they're the usual run of the sort of ones that are used and marketed, they do have to be used in caution with some people. They're not suitable for everybody. And for example, if you have cardiovascular disease, they may be inappropriate. So I think it depends very much on the extent of the heart problem, and the fact that the person's on urso would not in itself be a problem. But I would be cautious about giving a blanket yes if there's atrial fibrillation and bisoprolol, because it does suggest there may be heart conditions, and that may mean the risks of these weight loss injections are greater than is justified.
Mm-hmm.
Weight loss is something we've discussed on a number of occasions on these programs. It is a major issue for many people, and there's no doubt that both surgery and medical treatment can be of help in selected patients. You have to weigh up the benefits and the risks, and clearly being overweight in itself is associated with a number of medical and physical and other problems. The treatment also has its risks, but particularly heart disease would make me concerned. There are several other conditions, thyroid disease, some tumors, again, where weight loss injections are inappropriate. So discuss it with a specialist and see if it's right for you. But I would be cautious in the presence of heart disease, amongst other indications.
That's great, thank you. We've got a question about urso. If I forget to take by urso, should I double up the next time?
I think that's a difficult one. When I saw this, I started to think about, I think on the whole, if you miss the odd, one-off dose,
Mm-hmm.
My own feeling would not be to double up. I don't think doubling up will do any harm on the one-off. On the other hand, you don't want to get high levels. I think very few people are meticulous at taking long-term medication day in, day out. They know they should, but we're all human, except perhaps Mo, superhuman. Discuss it with your nurse or doctor, but the advice I would have given the patient in general is not to double up, just try and remember. And the important thing is to make it, rather like taking out your teeth at night or putting them back in the morning. It's something that you do routinely.
Yeah.
I think, as I say, missing the odd dose is normal. In the course of things, it doesn't matter. That's not true of all medications, I have to say. And there's somewhere really it does matter, and maybe you do want to double up the dose. But I think with urso, although it's a very safe drug and probably taking twice a dose probably wouldn't harm, my feeling is you could probably just say, I'll try and remember better next time. But we all, as I say, very few people, when there was a number of studies where they they put radioactive compound, safe dose in the tablets, put a monitor over the stomach so you could see when they were being taken. And I mean, with patients' consent, obviously. And it just shows how people are human. They don't take it at the same time every day over the long term because life gets in the way.
When I read that question, I also thought, I know some patients take all their Arzlo in one dose in the evening. So potentially it could be if you've missed one of your tablets during the day, or have you missed your whole daily dose, so that kind of went through my mind when I read the question as well.
Yes, I mean, normally again, talk it over with your own nurse and doctor. I think whether you take it spread out or a single daily dose, my own preference would be to take it as a single daily dose, A, because it's easy to remember, and B, I think it stops making you into a patient. If you're thinking about taking your tablets 3 times a day, you've got to take them out with you when you go to lunch and all the rest of it. But obviously, if you miss a dose, that's not quite the same as. So if you're taking, say, 250 3 times a day, and you forget the lunchtime, then taking the 500 in the evening would be fine. So I think it depends very much how much you're taking, how you're taking it, but provided it is the exception rather than the rule. I think if you're constantly missing doses for all sorts of reasons, you need to discuss that with your nurse and doctor and see if there are other ways that you can have so you don't forget.
I think taking it all in the one dose certainly helps a bit with routine as well, doesn't it? Because say you take it in the evening, and then that's part of your regular routine, so hopefully then that's remembered.
And in general, in other areas, say like post-transplant, where missing out a dose will be more important, have greater risk, people are showing that once daily dosing is associated with greater compliance than multiple doses throughout the day. So that's another, again, a very strong reason to think about. But treatment should be tailored to the individual and their lifestyle, and talk it over with your nurse and doctor if what you're doing is not suiting you.
Great, thank you. Next question is, I'm considering holidaying in India and wanted to know if I can take travel vaccinations, including malaria, yellow fever, etc.
Right. Vaccination overall, I mean, vaccines, like any other treatment, has risks, and you have to balance the risks and the benefits. People with advanced liver disease, people on strong immunosuppression, need to be cautious about vaccines in general, because some vaccines, again, they vary. Some vaccines are live attenuated ones, so that they're live vaccines like the polio, which has been treated so that it rarely causes symptoms. Some are dead vaccines, but the live vaccines have to be used with caution in people who are on immunosuppressed, and some people with advanced liver disease may be immunosuppressed because they're liver disease, or maybe immunosuppressed because they're taking immunosuppressive drugs such as corticosteroids, mycophenolate, and so on, cyclosporin, tacrolimus. Yellow fever is a difficult one. Rarely it can be associated with very severe side effects, and the MHRA has given advice about that. And in particular, in older people or people who are immunosuppressed, there may be reasons not to give it. What I would suggest is that the person goes to a travel centre, because there they can advise what the risks are of where you're going, the time of year you're going. So yellow fever can be a nasty condition, difficult to diagnose, difficult to treat, and then not everybody who gets it gets sick, but some get very sick. So you need to consider what are the risks of where you're going, and it'll vary throughout the time of year. Are there safer ways of avoiding, say, yellow fever by avoiding insects, which will cause a disease to infect you? And then age, medication, other medical conditions will come into the decision. So it's very much an individual thing, particularly something like yellow fever, where there are potential side effects, which can be very severe. And you have to look at the risk of where you're going. So it's got to be individualized. Go to a reputable travel center and seek their advice. But when you go, try and think, go in enough time, have it at your fingertips when you're going, where you're going, all the trips, and your medication, and then they can discuss with you. I think the important thing is you go if you've got liver disease, PBC, that shouldn't stop you doing what you want to do, just to manage it as the person obviously is. So get vaccines, immunization where the risks justify the benefits. So talk to the experts, but it's so dependent on when and where you're going, what you're taking, age, other conditions. So seek medical advice, but tailored for you rather than just a generic advice. But on the whole, vaccines are safe, but they're not totally free of risk.
Thank you. Our next question is, I'm due to see my haematologist soon, and I have a blood test to check my levels. I don't get details of the levels, just notified if they are acceptable. If since I found out that my ALP is 153, I do have access to the NHS app and can see blood tests from a GP, but not from any hospital visits. Is this normal practice?
It is ridiculous, isn't it, that the NHS is not joined up. I was giving a talk this morning to some American lawyers talking about the great strength of the NHS, but also some of the weaknesses. And although the latest Act, Health and Care Act 2022, I think it was, talks about joined up, it is not. Some hospitals, I know mine in Birmingham, gives patients access to their blood results. And I think it's important that people do have access to their results. It is ridiculous that you can get your GP ones on the NHS app and you have a different process. And again, so you may be going to the hospital and the lab that does the blood test for your GP is the same as the one doing for the hospital. So talk to your hospital. And personally, I think it's unsatisfactory to know if it's acceptable. I think if people want to know their absolute value, whether it's 153 or 200 or 90, they should have the right to know that because it's your results and you should have the right to know that. Different hospitals, as I say, some hospitals give access to patient records. Others aren't yet that advanced. And it is ridiculous in the NHS that with the government IT projects share two features. They're enormously expensive and usually fail. And the NHS has spent literally billions. We talk about waste in the health service, but things like wasted IT initiatives, because I think they're top down and managed by people who aren't experts, but that's just a rant.
From my personal experience, I find that my hospital send the letter with my blood results to my local GP, and they also send me a copy. So it's a general letter about my appointment and what was discussed, but it also gives my blood tests at that point as well. And I know also that if I go in and ask at my GP surgery, if I haven't received it from the hospital, they would print out any ones that are local to there, or ones that have come in from the hospital as well. So I think it might be worth, if anyone's having problems getting a hold of them, is just discuss it with their GP surgery as well and see if they could get a print of them.
Yeah, but I mean, I share that person's frustration that it isn't all joined up and people aren't given access to their results.
Yeah, because my hospital's in a different NHS area than my GP surgery. So it wouldn't automatically appear locally either. So, and it can be a bit frustrating.
But even so, I know within my own area, served by Cheltenham Hospital, that people who have a blood test at Cheltenham, organised by the hospital, can't access it through the NHS app. It's stupid, but the way it is.
We have a patient asking, they've been recently diagnosed with PBC and have been working in a small engine shop for the last 8 years, which has poor ventilation with petrol fumes throughout the shop. Could this have attributed to me getting PBC? It's an interesting one.
Interesting. I think the question is unlikely, but as we don't know what causes PBC, as we don't know the risk factors for getting it, one can never exclude it. And I think, as always, one has to keep an open mind. There have been many epidemiological studies looking at factors that are associated with PBC. And although things like nail varnish, hair dye, and some come out as very, very weakly associated with PBC, I'm not aware that occupational exposure does. But then, of course, that hasn't, as far as I'm aware, been particularly looked at. So there's no evidence to support that I'm aware of. There is a causation. Certainly, some hydrocarbons can cause liver problems. And if there is poor ventilation, that's a health and safety issue in its own right. But I'm not aware that it causes PBC, is associated with PBC. But it's one of those comments that you file away, and if you get 3 or 4 more people, you may want to look at it closer. But I would say there's no evidence, but that doesn't mean it doesn't.
Thank you.
Yeah.
Is it normal for periportal lymph nodes to grow? This patient had received an ultrasound every 6 months, but this one seems different. Multiple periportal lymph nodes, the largest 2.6 by 1.3 by 3.2. The largest was previously documented at 1.5. Ascites, trace fluid adjacent to the right lobe of the liver. Although I've noticed that in my questions that I've sent over to you, I've put right love of the liver, but I quite like that as well, because we do have to love our liver. So adjacent to the right lobe of the liver. So just asking if that's normal.
Enlarged lymph nodes in the abdomen are associated with a number of inflammatory liver conditions, including PBC. And if lymph nodes are enlarging, I think one needs to be aware of that. And if it's 1 or 2 lymph nodes, I think one wouldn't necessarily be concerned, but would need to monitor it. And again, it's something to discuss with your doctor. If I saw a patient with enlarging lymph nodes, again, if it's all the lymph nodes or some of them, how quickly they're enlarging, how it relates to the inflammation in the liver, those are all factors that come into it. So it's something to be aware of and to monitor. And if they're concerned, to take it further, because just because you've got PBC doesn't mean everything you find is because of the PBC. And there are other conditions that could result in enlarged lymph nodes. But again, it depends on the clinical situation. Is it 1 or many? How quickly? And the other thing to be just to put in the mix. With any measurement, remember there is some degree of biological variation. Different machines, different days, you do get slightly different results. So it's the trend that you're looking at. But again, it's something to discuss with your doctor and make sure they're aware. And depending on the situation, you may want to repeat the imaging sooner rather than later. And finally, and I'm sorry, go on a bit, a measurement you get on ultrasound and the measurement you get on MRI or CT, they don't always equate. And so compare like with like. So ultrasound measurements with ultrasound measurements rather than ultrasound with CT. I mean, obviously, if you do an ultrasound, say in January, and it's 1 centimeter, and you do an MRI scan in 12 months and it's 15 centimeters, then that's a real finding. But small differences, again, may not be significant. So talk it over with your doctor. It doesn't necessarily mean there's a problem, but you want to make sure this is just part of the PBC and nothing else.
Great, thank you. I would like to know more about being ANA GP210 positive but AMA negative. And is it a fact that PBC diagnosis by this method is more aggressive?
Right. Just to give some context to that, as I suspect most people still awake on this call will know, that the PBC is associated with the antimitochondrial antibodies, which is an antibody reacting with a protein on the mitochondria, which are the energy organelles within nearly all human cells. There's a couple of other antibodies that are associated with PBC, one of which is the GP210, and that is something called, that reacts with the is a nuclear pore complex, which is an area of the nuclear membrane. It is very closely associated with PBC, and people who are, and it is one of the anti-nuclear antibodies that's associated with PBC and not with autoimmune hepatitis. Yes, GP210 is associated with a slightly more aggressive form of PBC. That is very much the evidence. What I don't know, and I tried to look up but couldn't find the answer, is the response to treatment different? Is it better? And sometimes we see in other conditions that more aggressive treatment, more aggressive disease responds more effectively to treatment. And what I don't know is whether response to URSO or second line drugs such as OCA and others, whether that's better or worse with GP210. The reality is, as I say, untreated GP210 do have a more aggressive course than AMA positive patients by and large. But like all these things, applying it to the individual, you don't know what would have happened if you'd been different. And it is what it is. The treatment approach is still the same. You may perhaps have a slightly, if you're an URSO non-responder, you may have a lower threshold to go on to second line treatment. But the GP210 positive, AMA negative people in general have a more aggressive course than those who are negative for the GP210. And so
just
that might affect your treatment approach.
Yeah, sorry I interrupted there. I was just going to mention that we'd actually had a follow-up question, and a separate question, but it follows on to that, and that was, does a negative AMA ever change? So once you test negative, are you always negative, or could that change to positive over time?
In the older days, certainly, when tests were less, it was done by immunofluorescence, a different technique from the ELISA now, then people sometimes do fluctuate. And some people on ERSA who are AMA positive become AMA negative. So I think the other thing to say is that the way you measure the amount of AMA in the blood is by titer, so you dilute it out. And most people would say that a titer of less than 1 in 40 is negative. So sometimes people who are AMA negative, actually, when you test with other methods, are positive at low titer. So it's not an absolute, but I think some people who are negative do become positive over time. I don't think there's any significance, good or bad, in that. But we know that the amount of AMA you have in the body, in the blood, doesn't really correlate with anything. If you're AMA positive at a high titer, you don't necessarily have a better or worse course than somebody who's got much low levels. Mm-hmm. And ERSO does seem to bring titers down, but not hugely.
Okay, thank you. So we've got a patient who's saying, after taking Urzol for 4 weeks, my bloods are nearly normal again, and I was told this was excellent. I was sent for a FibroScan and told the results were normal. However, when I received my letter, it stated 7.5 kp, CAP 179, and IWR 14%. The letter also stated I had mild to moderate scarring, although I'd been told verbally that my scan was normal and nothing to worry about. The patient is a bit worried. They think they've received conflicting information.
Yes, it sounds though there is conflicting information. The scan results are slightly abnormal, I would have thought, for most measurements. But if there is conflict and you're getting mixed messages and uncertainty, there's only one thing to do, and that's to go back to the doctor or nurse. Mm-hmm. Was it the doctor? You'd be interested to know whether it was the nurse or the doctor, the same person who gave the verbal as the letter. But certainly get the conflict resolved, and a letter or phone call asking for resolution. It's not worth worrying about. It's worth doing, but it is worth doing something about it to stop that worry. And the simple thing is to go to the individual and say, did I understand correctly? Or did somebody change their mind or read up and looked at normal values or whatever?
I think that's good just in general advice as well, isn't it? If you receive your update from the hospital and it's not what you took away from it yourself when you're at your appointment, then follow up and make sure that you've understood correctly in case there is something that you have misunderstood.
And again, if I could just reiterate something that you and we've all talked about before, is clinic appointments are often stressful times, not just because you have to find somewhere to park and get there on time and then wait for 2 days in the waiting room. And it's always a good idea to bring somebody else with you, because 2 pairs of ears are better than one. And think of the questions you want answered, write them down. I find is better because you forget otherwise, and bring somebody with you who can help remember the answers, and make sure that you get your questions answered. Sometimes, like I do, I answered the wrong question.
No, and I think that's certainly where we can help as well. I know if patients are preparing for an appointment that might be a bit more complex or just need some help and the right questions to ask, we can spend time with patients and help them prepare for that. But I would say, and I certainly do it myself, I would write things down and take it in, and then you can just refer to it, because often in the moment you do forget, and you're not sure when your next appointment will be. So absolutely be prepared, be informed and prepared.
And remember too, from the point of view of the doctor, it's much to have when you see somebody, you want them to go away satisfied. They may not like the answers you give them, that's a different issue, but to have somebody and an informed patient is a lot easier for the doctor than a misinformed or uninformed patient. because what you want is, with something particularly like PBC, a chronic condition with symptoms that can affect hugely the quality of life. You want them to basically take responsibility for that condition, take ownership of it, and with information, and information that is correct, and going back to the conflicting information, you start to worry, you start to read a lot more into this. I know I've done it. And so you're helping the doctor and nurse as well by being informed and getting resolution of your uncertainties. And I don't think any doctor worth his or her salt would do anything other than welcome that.
Good. We're certainly here to help with that. We want to empower patients to have all the information they need for their appointments as well. So if anyone wants to have a chat about that, please just give us a call or get in touch by email. We've got a couple of questions in general about Urso prescriptions now. So the first one is, my Urso tablets have changed to orange from white. I was given them previously and they didn't agree with me. I asked the pharmacist to change them, but they weren't able to do that on this occasion. Is there a difference between the white and the orange coloured tablets?
This is a difficult one. In theory, that any tablet that is licensed in the UK, as indeed in many other countries, contains the same amount and the same quality of active ingredients. You can present the same 250, say, of Urso in different forms. And if you think about, for example, just paracetamol, you can get paracetamol as tablets, as capsules, as liquid, as soluble patch, and so on. You can get it in various forms. They will all contain usually 250 or whatever it is of paracetamol. But they do come in different forms. Coloring and what makes up the tablet or capsule or whatever will vary. It is not random because it has to be such that it retains the integrity of the active ingredient. There's not something that'll interact. Color is important, believe it or not. We know, for example, that painkillers are much more effective if they're red than if they're any other color. Sleeping tablets are much more effective if they're blue than any other color. And there's a lot of research that's gone into that, which shows, particularly for things like, as I say, anxiety, sleep, depression, pain relief, where there's a lot of individual response to the treatment, the color does seem to have an effect, and there's objective data to back that up. With Urso, I would have thought the color is immaterial. There are, now that Urso's off patent, I believe it is, a number of different companies will produce Urso to be licensed in the UK, as indeed any other country. It has to pass certain strict tests of purity and quality and so on. Pharmacists, hospital or online or on the high street, will usually go for the cheapest or the most readily available. So in theory, it shouldn't matter, but there are some occasions when different color, different compositions do have cause symptoms. Say, for example, you might be allergic to or intolerant of some of the compounds that go in to stabilize the tablet or capsule. So in theory, it shouldn't make any difference. In practice, it can do. And check with your pharmacist. In terms of efficacy, it shouldn't make any difference. In terms of side effects, tummy upsets, intolerance, that sort of thing, it could do. So just go to your GP, go to your pharmacist and tell them. But in terms of efficacy, I think it's unlikely to make any difference because it's properly regulated. in terms of side effects, then I can see them slightly different preparations having different effects. And if you find that this form of urso is intolerant for you, then let the chemist know.
And see if an alternative can be provided, yeah.
But only if you're getting symptoms from it. If it's just different colour, different manufacturer, then it probably doesn't matter.
Another one along the same line, we've got a patient asking, can you please advise if urso is classified as a substitutional therapy in regards to medical exemption certificates in the UK, specifically in the Southwest, Gloucestershire, for free prescriptions?
The list of drugs which are available for free is a bizarre list. It goes back decades and seems to have no logic in today's practice. So some drugs, like thyroid drugs, give you exemption. As far as I know, urso is not on the list. There are two things that I would say. One is, if you're paying a lot for your prescription, you can buy a season ticket. It's not called that, but I think it's £112, which means all your prescriptions are included. You can also, if you're paying for your prescriptions, if your doctor prescribes as a monthly preparation, you could ask for 3 monthly, and you're still paying only one prescription price. And if you have financial pressures, then some people are eligible to free prescriptions for that reason. But as far as I'm aware, urso is not on that list. I suspect the government would like to get rid of it, but the upset it would cause would just be not worth it. But it is an anachronistic approach. Some non-essential drugs are included, some life-saving drugs aren't included. It is slightly bizarre. So I think the short answer is, as far as I'm aware, no.
But there are ways potentially to get help, either to think about buying the yearly subscription for your prescriptions, and also if you're struggling for paying for them, there will be help available for that as well.
Or ask your doctor to give you a greater supply.
Yeah, because I think once your dose is settled, we know that's going to be the case for a while, so there shouldn't be any problem with getting a bit of a longer supply at that point.
Yes, I think it doesn't apply to PBC, I suspect, but there are quite a lot of conditions where people have been getting their monthly or 3 monthly supply and stockpiling it. They've stopped taking it for one reason or another, and I know several people who've come back with bucket loads of drugs they've accrued over the years, and you think, what a waste.
It's managing the balance of that, isn't it?
Yeah. I would personally, I think most people don't appreciate how much medication costs the taxpayer. And I've always thought if they put the price or the cost to the NHS or to the taxpayer on not only drugs, but x-rays, outpatient appointments, blood tests, I think people would be slightly less profligate. Most people don't appreciate, and why should they, say the cost of an operation or cost of a treatment or an x-ray. Just have a look at the private sector, see how much your local private hospital charge for an MRI scan, and you realize what the taxpayer is paying for.
For the services, yeah.
So we have a patient who listened to the webinar last week with Dr. Kramer and Robert, and a question was asked regarding PBC and high cholesterol. And the doctor had said that 75% of PBC patients have high LDL, and it doesn't present the same blockages in the arteries as a person without PBC. And he had said he wouldn't treat with a statin in his clinic. So this patient has PBC. They've got high LDL cholesterol at 6.5 overall, but no diabetes, high blood pressure or obesity. They're 69 and would rather not be on statins if necessary. What would your advice be?
My advice would be talk it over with your GP. there are a number of issues here just to consider. The first is that people with PBC do have high cholesterols due often to an increase in one of the good cholesterols called lipoprotein X. And therefore, cholesterol, say, of 7 in somebody without PBC is of far more significance than somebody with PBC of cholesterol of 7. Mm-hmm. And things like looking at HDL and LDL and their ratios is important. The second point I would say is that there is increasing evidence now that statins have a benefit in the elderly, irrespective of the cholesterol level. And there's some views, which I personally subscribe to, that prescribing statins to people over 70, whatever their cholesterol, is a good idea in general. Obviously, if you've got risk factors such as a family history, high cholesterol, you're smoking, past heart disease, then there's a question for statins. They are, on the one hand, you don't want to take medication unnecessarily, but there is some evidence that statins will benefit, particularly the older people, irrespective of the cholesterol level. Mm-hmm. So I would agree with what was said last week, that you wouldn't routinely treat a high cholesterol in somebody with PBC. You look at the individual, their risk factors, family history, and so on. But as you get older, there is an argument for considering statins irrespective of PBC. And so now I'm over 70, I do take a statin, not because my cholesterol's fine, it's 3.2 for what it's worth, but because I think it will stave off some conditions such as Alzheimer's. Mm-hmm. My wife might argue that's too late, but that's a different matter. But again, talk it over with your GP, mm-hmm. Get the facts, get the information, and then decide whether you want to take the medication or not.
I think they've had a wee bit of a difficulty with their GP because the GP only has a little knowledge of PBC. So I think just by default they're offering her the statin. I think I'm just trying to think if there's anything we could send in terms of information that would help with that for her sharing with her GP.
I think if the GP doesn't know a lot about PBC, they won't talk about it with your hospital doctor. When I was at Birmingham, we had a very good lipid service, and we worked closely with them so that the doctors running the lipid clinics would be able to adjust the advice, knowing the fact the person's got PBC. Mm-hmm. The bottom line is that people with PBC don't have an increased risk of heart disease, although they do have a risk of high cholesterol. So the high cholesterol doesn't translate in this case necessarily into heart disease. But if the GP is not aware of the lipids and PBC, then I'd talk to your hospital doctor and maybe get a referral if there is an expert locally available. But talk through it. There are risks and benefits. It's not a straightforward mm-hmm. decision. And anyway, it's up to the individual to decide whether they want to take the drug or not. Usually it's very well tolerated. It's cheap as chips. But it does have risks, yes.
Okay. I'm going to move on to some questions we've got live coming in on Facebook. So we've got someone asking, sorry they're late, but they've caught COVID for the first time. This is day 4. Will having PBC impact on my recovery time?
I'm sorry to hear you've got it. It's no longer fashionable. It's just a darn nuisance. And I think probably it will have little impact. Doesn't mean the fact you've got PBC depends on the state of PBC and your medication and other conditions, but on the whole, it probably won't have any lasting impact on the severity or whether you get long-term symptoms.
Mm-hmm.
So I think it's unlikely unless you've got
Okay.
very advanced disease.
Great, thank you. This question took me back a wee bit, I must admit. I'm on URSO for the last 13 years, just had a medicine review with my pharmacist. She asked, do I still need them? I am a responder.
Very simple question.
Very simple answer.
Yes.
Yes, absolutely yes. Yes.
I mean, I think it's absolutely right that people question the need for it. I think you always want to do that. But
it's good that it's good that they're reviewing a medication with her, but just understanding that because of the type of condition, it will be continued.
And if she does or he does want to change, then don't take that. Talk to your hospital consultant, and they can advise the pharmacist. But as I say, don't take it personally. They've said, do you still need it? That's a very good question. It's a question that I'm sure people with a post-transplant have asked about their immunosuppression as well. Do I still need to take it? Always challenge. And if people challenge you, then it's not a bad thing. It's a good reflection.
Okay. So we have a question from a patient who's been on URSO for 8 years. Liver is getting worse. Consultant has tried every other medication available and nothing is working. So basically been told to wait to qualify for a trial. They're really fed up and struggling. I think this patient would benefit maybe from a helpline call as well, so that we can chat through that in a bit more detail. So I would invite the patient to give us a call to discuss it. But I just thought I just wanted to mention it while we were live, so the patient realised that as well.
I think a phone call is a good thing. Discuss, see what's been tried, see, talk it through with your consultant. That's something where you don't particularly want a junior or a nurse. You want somebody who knows what's happening in the field, who knows what trials are opening up, and to make sure that all appropriate options have been tried. So I think a phone call, but that there are times when you tried all the treatments and there is nothing available, and sometimes it is the right thing to say, look, you're on the best we have to offer at the moment. It's hard. It's hard to say to the patient, hard, I'm sure, to accept it. But talk to the foundation, see what they say. Talk to your consultant. Think about a second opinion if that's, and that's always an option that you should consider. And if they tell you the same, then you can be reassured that's the best. But it is not an ideal situation. It is tough. Imagine fed up hardly covers.
Exactly, So please give us a call on the helpline. We'll chat that through with you, go through the treatments that have been tried, and then we can see what can be done before you then follow that up with a chat with your doctor. But I think a chat with us would be really good, just so we can go through that with you. So we have a patient who's asking, they've just recently started on OCA. Should their blood pressure have rocketed, they're having palpitations? Is that a known side effect for OCA?
Not that I'm particularly aware of. I may be wrong on that. But again, let your doctor know, or your nurse know. It could be related, it could be unrelated, but certainly if you're getting very high blood pressure, that needs sorting out. As I say, I know what I would do, but I think it's got to be tailored to the individual. So go back to your doctor. If you've got recordings of your blood pressure, bring them along with you. If you've got palpitations, again, take your pulse and note down any symptoms you get from the palpitations. And that gives some factual background. And then you can decide where to go from there. So it's not a common side effect, put it that way, I think, and Mo would agree.
It's not something that I had heard before either, so that's why I thought it'd be worth just asking if it was recognised. You know,
I say it may be recognised, and that may be my failing, but talk to your
I'll
doctor.
check on it as well. Yeah. Right. So we have a newly diagnosed patient with PBC. Fibrosis scan showed mild to moderate damage and ALP around 200. Will taking my urso and healthy diet and exercise get my liver back to a normal level?
I can't guarantee it will get everything back to normal. Treatment and exercise will certainly help, and stopping it getting worse. Whether it will turn to normal, I think, is less certain. But if you can hold it as it is, then that's a great bonus. So carry on with a healthy lifestyle, whether or not you've got PBC, and keep taking the urso if you've got PBC. If you are a responder, great, carry on with the urso. If you're not a responder, then go on to second-line treatment. But the aim, certainly with mild fibrosis, the important thing is to stop it progressing. People live with mild fibrosis, and of course there may be many other causes other than the PBC for it. You know, if diabetes, overweight, and so on.
We mentioned earlier that when I upload this to YouTube later on today, this will be our 100th video on YouTube, our Q&As. I'd also like to say that there is so much information on there in other forms as well. So we have input from our patient conference last year. So there was a dietitian that we had with us there, Professor Moore, who talked us through healthy eating for liver. So these are all uploaded to YouTube as well. Please have a look around there. There's so much information up there as well. So there's, especially for newly diagnosed, there's lots of information that you can have a look about. And once you've done that, any further questions, please just reach out to us as well.
Sorry, can you just echo that and reinforce it? If there are topics that are not covered by the videos and information leaflets and sheets and booklets and so on, do let the foundation know, because we're keen to.
We'll get that covered, yeah. And what we've been doing quite a lot recently is if we've been having a chat on a Q&A about something in particular. There was an example a couple of weeks ago where we had quite a lengthy chat about anemia and PBC. So we made a little special out of that. So we clipped it just to the information about anemia. I did one where I'd previously done with you, where you went through all the pain relief and different types for it. I made that into a little special so that if people phone up, we can direct them just to that one question and answer as well, which has been really useful. So there is lots of information. And
do provide feedback, because that's that's how the best, even easiest way to improve.
Absolutely. If there's anything that you feel that's missing, please just let us know and we'll look at that. Now, I know we're hitting almost 3 o'clock, but we have one question that's come in live that we haven't got to, and I would really like to, if that's okay. So I would just like to ask the last one before I let you go. So we have a patient who, after 7 months of blood tests, was informed 2 weeks ago by phone that they had PBC, but all the bloods are normal now. They've never seen the results, but something was 113, but now 46. Doc is writing to the gastroenterologist to see what to do next. Should I be on any meds or doing anything myself? Doctor only treated 2 patients in his career and doesn't know much about it. I'm 61 and living in Northern Ireland.
Right.
So it looks like the blood tests they were high and they were diagnosed with PBC, but then the blood tests are back to normal now.
Yes, I think it's a difficult question whether AMA positivity, if that's what the diagnosis is based on, with normal liver tests is something to treat. There is some diversity of view here, but again, the fact you've been referred to a hepatologist, and there's some very good ones in Northern Ireland, means you'll get the right advice for you. There's nothing, and assuming the waiting time is not ridiculously long, there is no urgency for any treatment. The only thing I would say is if you're AMA positive, you really shouldn't be doing the washing up. Leave that to your family. I'm
showing that to my husband.
So from what was said, my guess is that they were found to be AMA positive. And again, whether treatment is indicated in the presence of normal liver tests, I think talk to an expert, and see what's right for you, weigh up the pros and cons. It's always a difficult one, but 61 is still, certainly for where I am, is spring chicken.
Absolutely.
And the rationale for treatment, if it is recommended, would not be to make you better, but to keep you well. And that's the thinking behind it. But it does mean taking medication. It does mean all sorts of things. So discuss it with the experts who will put it in context and give you the right advice. And your GP is absolutely right. To have treated 2 or 3 patients doesn't make you an expert. And the GP's done the right thing in referring for somebody who lives and breathes it.
And I think, just as we touched on earlier as well, that's why it's so important that as patients we're informed as well, so that we can share that. So I would say as well, just because you're newly diagnosed, please, if you want to have a chat, please reach out as well. We'll have a wee chat with you on the helpline and see if there's anything else we can do to help. So thank you so much for joining us today. As I said, when I upload this, it will be our 100th one on YouTube. So I feel that there's a bit of a celebration to be had for that, because that's quite an achievement. And I really appreciate you taking the time to join us. Thanks to everyone too who submit their questions. If there's anything that we didn't get to this week, I'll make sure it's added on to the session for next week as well. And thank you so much. It was really nice to see you again, Professor Neuberger. It's always lovely to see you.
Nice to be back, and congratulations on the 100. Whether I'll be alive for the 500th, I'm not sure.
we'll make sure of that. We'll make sure of that. So thank you very much.
Okay. All the best. Have a good afternoon.
Take care. See you later. Bye.